A very warm welcome to this talk. My name is Dr. Sayed Kazmi. You're watching my YouTube channel, and in today's video, we're going to talk about dermatology. So we would be focusing today on bullous skin eruptions. So let's dive in and get started, and we start with the help of a clinical case scenario. So this is a 14-year-old boy whose name is Andrew, and he presents to the pediatric emergency department with a complaint of very swollen red eyes, oral and genital ulceration, and a throat that is covered in slough. So he's got like conjunctivitis like symptoms, and he's got a massively inflamed throat which is covered in exudates. He complains of a burning sensation when he passes urine. So on top of it, he's got dysuria, and he's got a 1-week history of ongoing headaches, lethargy, and myalgia. He's also been taking amoxicillin for the last 2 days, which he has taken in the past without any adverse reactions. So he's currently on amoxicillin for the last 2 days, and there is a past history of using amoxicillin which he has used for different infections in the past without any adverse effects. Now, this boy Andrew also had his meningococcal vaccine 7 days earlier and had felt unwell following this. So he's been feeling unwell since he had this meningococcal vaccine. Now, when you examine him, he's got swollen lips, he's got swollen mucous membranes inside his mouth, and he's got red conjunctiva in addition to ocular, oral, and genital ulceration. So you find he's got very swollen lips, he's got ulcers in his mouth, he's got conjunctivitis, and he has got ulcerations in his eye, like maybe probably you have stained it at fluorescein and you see that there's corneal and conjunctival ulceration, and he's got some genital ulceration as well. So probably he's got some form of balanitis or balanoposthitis. He exhibits no respiratory or cardiovascular symptoms, so chest is clear to auscultation, and he's got no lymphadenopathy. He's febrile. At the moment, his temperature is 39 degrees Celsius and his heart rate is 108 beats per minute. So it's not overly tachycardic, but he seems unwell. So there's a history of which apparently looks like probably he's got a generalized viral infection. But on top of it, what is significant in this particular case is that he has got conjunctivitis, he has got pharyngitis, probably tonsillitis as well, and severe genital ulceration. So what do you think of this case? Now, apparently looks like probably he might be having a streptococcal sore throat with some mucous membrane and skin involvement as well. You know, streptococcal bacteria, they can secrete exfoliative toxins as well, and there can be skin involvement sometimes. So obviously you can think of staphylococcal infection, but he's been taking amoxicillin, so if it was staphylococcal infection, he should have responded to it. Then what else could be the reasons? Like, you might even think of staphylococcal scalded skin syndrome, but staphylococcal scalded syndrome, there should be some diarrhea, and obviously it presents more like a shock-like condition, which obviously is not in this particular case, because temperature is 39 and his heart rate is not very high. So what could be this condition? Now, obviously, the first thing that you think about are infections, staphylococcal infections. But this particular case, where there is a febrile illness which looks like a generalized viral infection, and on top of it there is mucous membranes and ocular and genital involvement as well. Think about Stevens-Johnson syndrome. So Stevens-Johnson syndrome is one of the bullous skin eruptions, which is not that much common, but if it happens, this is basically one of those rare dermatological emergencies that need to be treated there and then. So the child would definitely need to be admitted, and some workup and management has to be given to this particular child. So let's move on to the next slide. And already I have discussed this case, so moving on. So coming to the Stevens-Johnson syndrome. So what is Stevens-Johnson syndrome? Basically, this is an acute inflammatory condition of the skin and mucous membranes, and this is caused by multimodal hypersensitivity reaction. What does this mean? Basically, inflammation. So in the skin there is inflammation. So at the junction of the epidermis with the dermis, there is a hell of an inflammatory reaction going on. And what has caused this inflammation? This is basically a multimodal hypersensitivity reaction. So multimodal means that there are different modes which are involved. So it involves CD8 cytotoxic T lymphocytes. It contains other types of inflammatory mediators like interleukin 2, interleukin 6, tumor necrosis factor alpha, and some of the other chemicals which are released by macrophages, monocytes, so on and so forth. So it's a multimodal hypersensitivity reaction involving the skin and the mucous membranes. Now the $1,000,000 question is, what causes this multimodal hypersensitivity reaction? So again, nobody knows actually what triggers this thing, but again there are different types of theories for that, because there have been association with certain types of drugs and infections, and they say it usually caused by either infections, either drugs, some types of paraneoplastic association, or in many cases we don't know, even despite having extensive investigations, what has caused this type of hypersensitivity reaction in the skin, and we call it idiopathic. Again, the list of infection is a huge one. Honestly speaking, any type of infection can lead to Stevens-Johnson syndrome, but they say most commonly it could be some of the viral infections like herpes virus infection, mumps viral infection, Coxsackie viral infection, Epstein-Barr viral infection, adenoviral infection, different types of bacterial infections like streptococcal sore throat infection. It can be caused by a variety of different types of drugs, especially the non-steroidal anti-inflammatory drugs, the sulfur-containing drugs like the sulfonamides. It can be caused by anticonvulsants, sodium valproate, lamotrigine, so on and so forth. It can be even associated with certain types of cancers. In that particular case, we call it as a paraneoplastic association, because when the cancer cells are growing and the body own immune system is trying to fight it off, in the process sometimes there is miscalculation, and the immune cells can start attacking the skin and the mucoid membranes, resulting in this particular situation called SJS, or Stevens-Johnson syndrome. Now the hallmark of this Stevens-Johnson syndrome is that there would be skin and mucous membrane involved. So at least one or more mucous membranes or mucous cavities are involved. So it can involve the oral cavity, it can involve the eyes, it can involve the nasal cavity, it can involve the oropharynx, it can involve the genital mucous membranes, and whatever you can think of, all those mucous type of membranes. So in a nutshell, this is basically a multimodal hypersensitivity reaction caused by a variety of different things, but by the end of the day, it's basically a multimodal hypersensitivity reaction. So somehow the immune system misreads the whole scenario in which they are activated, and they start attacking the cells at the junction of the epidermis and the dermis, and that leads to severe skin inflammation, leading to bullae formation, vesicle formation, ultimately ulceration. And then if you think of what happens in a burn, the same situation happens in Stevens-Johnson syndrome, because Stevens-Johnson syndrome, you can think it as medical burns basically, fine. So moving on to the next slide, pathogenesis. Coming down to the pathogens, what is happening in Stevens-Johnson syndrome? So basically, as I told you earlier, that whenever there is an antigen and antibody reaction, wherever this antigen is coming from, it could be your body's own cells, or it could be antigens from outside, from different viruses or bacteria. So this antigen presentation leads to activation of the antibodies and other types of T cells, especially the T cells have got a lot of involvement in this. So that interaction, when the antigen is being hit by the antibody and the antigen presenting cells, the T cells and other things, so what happens is that there is release of chemical mediators. These chemical mediators like interleukin 2, 6, tumor necrosis alpha by the local tissue dendrocytes. So they release these chemicals. Now these chemicals, they are chemoattractors, so they invite other inflammatory cells in that particular area. So that results in the recruitment and augmentation of the T lymphocytes. So the T lymphocyte, they start coming, so hordes, like the whole regiments and battalions of T lymphocyte, they start pouring into that particular area, and then they themselves start, secreting different types of lytic enzymes. It's going to like destroy the cells. So what happens in this particular CD8 positive T lymphocyte, which is also known as a cytotoxic lymphocyte. Remember, these are known as a cytotoxic lymphocyte because they have got the CD cluster determinant 8 on their self-surface. So these are very important in the pathogenesis of Stevens-Johnson syndrome. So when they are invited, what they do is they have got like a special type of chemicals known as granzyme and perforin. So granzyme is basically a lytic enzyme. So with the help of perforin helps to attach this granzyme with the cell of the keratinocytes, and what happens then, this granzyme goes inside, and granzyme is known for causing apoptosis or programmed cell death. So it goes inside the skin cells. What it's going to do is going to tell the skin cell to die. It orders them to commit suicide, or it simply destroys them if they're not committing suicide. The cell is broken down. Obviously, the other chemicals which are released from this dying, they also further aggravate the situation. More chemicals are released, and that leads to severe inflammation in the skin, and that is exhibited in the form of inflammatory macules, vesicles, bullae formation, and ultimately they would burst open, releasing the raw surface beneath, which would then cause the moisture to evaporate. And then obviously once the skin barrier is broken, opportunistic infection or secondary infections can happen in that, and obviously it would act like a burn, maybe an infected burn, and then can have serious complications. But remember, the important chemicals here are granzyme and perforin, which are basically released by the CD8 plus cytotoxic T lymphocyte, which got a role. So remember, Stevens-Johnson syndrome, CD8 positive T lymphocytes via perforin and granzyme. So these are important points, takeaway points from this pathogenesis part of the SJS. Now coming down to the signs and symptoms. So signs and symptoms, very treacherous. Like, it always starts with symptomatology which mimics a viral illness. So like they've got fever, they've got cough, sore throat, headaches, body aches, things like that, which can happen. These are the myriad of symptoms which happen in almost every type of generalized viral infection. So obviously people think, oh well, it's just like the viral infection, maybe seasonal, maybe something, and nothing to worry about because this is so common. But what happens within the week times, the skin and mucous membrane involvement starts. Now as far as skin is concerned, we know many of the, especially in pediatric population, viral infections are related with viral skin rashes. We call them viral exanthems. So common, unless and until there is very extensive involvement, nobody takes them seriously because they're so common. But when there is a mucous membrane involvement, that is the first red flag. Okay, something click that, well, it could be some form of bullous skin disease. Bullous skin disease are always taken seriously. But these are not like all of a sudden the skin would come up in bullae. It usually starts with macules. So there are inflammatory red spots which might change into papules, and these papules then they turn into vesicles like clear fluid, and then they become bigger, becoming bullae, and then bullae can burst open, leading to ulceration, and then they can heal with the incrustation as well. And one of the hallmark of Stevens-Johnson syndrome are target lesions. So these are target lesions. So target lesions mean that in the center there is this vesicle which has burst open, so obviously it would encrust. So there's a dark area that is surrounded by an area of edema. So the skin has got edema in that. So that is an area of clear or pale coloration, and then at the rim there is more inflammation which is spreading. So it acts like a target. If you have seen those, the target sign where you have to throw a dot and it hits the target, the center of the target. So you would see dark spot in the center, which is the area of necrosis or area of cell death, followed by edema, which is clear, and then an area of raised erythema or inflammation. So it acts like a bull eye target lesion, which is a hallmark of Stevens-Johnson syndrome. Now, Stevens-Johnson syndrome is considered to be a part of a spectrum, because on the lower end of the spectrum, this is what we call the erythema multiforme minor. So erythema multiforme. So erythema unknowns, it's a skin rash. Multiforme, there are different types of rashes. So you, in the same rash, you would see papules, macules, vesicle, bullae, but like there is only skin involvement and no mucous membrane involvement. So that is the lower part of the spectrum, and that's known as erythema multiforme minor. Erythema multiforme major is when there is one mucous membrane involvement, like the mouth, and if there are two, then we call it Stevens-Johnson syndrome. And then again, on the other end of the spectrum is the 10, which stands for toxic epidermal necrolysis. Now the difference between SJS and 10, they are the same thing. The only thing is, in Stevens-Johnson syndrome, the skin involvement is less than 10% of body surface area. So just like a burn, which is less than 10% BSA. But if it is more than 30%, we call it toxic epidermal necrolysis. In between, if somebody has got between 10 and 30%, that would be SJS10 overlap. So we call it Stevens-Johnson syndrome with TEN overlap, because that's between 10% and 30%, which is the sort of a no man's zone where, well, you can say partly Stevens-Johnson, partly 10. But if it's less than 10%, it is SJS. If it is more than 30%, it's toxic epidermal necrolysis. If there is no mucous membrane involvement and you see this only on the skin, that is erythema multiforme minor. So this is part of a spectrum where you can see either it might start as erythema multiforme minor, ultimately changing into SJS, and may even go to toxic epidermal necrolysis, which is a very grave condition because it acts like more than 30% burns, which carries a very high mortality rate. So you can see in this picture, if it's less than 10% body surface area, SJS. If more than 30%, we call it 10, and then if there is between 10 and 30%, we call it the SJS10 overlap. Now, in order to determine the severity of this condition, because it can carry a very high mortality rate if it remains untreated, for that we use the Scorton severity of illness score. So Scorton score is used. So there are marks used for that. So either you give 1 mark if that condition is present and 0 if it's not present. So you look at a few things. So age is one factor. So if somebody is greater than 40 years, he gets 1 mark. If it is less than 40, it's 0. So all pediatric cases, they will get 0 on this one. If it is associated with malignancy, you give them a 1 mark. If no, then 0. If it is associated with tachycardia, if the heart rate is more than 120, again you would give them 1 mark. If it is less than that, then 0. If the initial surface of epidermal attachment is greater than 10%, again you would give them 1 mark. If no, 0. And then you check certain biochemical parameters as well. So if urea is greater than 10 millimole per liter, which means dehydration, you will give 1 mark. If the serum glucose, if there's a hyperglycemia greater than 14, you give them 1 mark. And if the bicarbonate is less than 20, which means acidosis, you will give them 1 mark. For the rest of them, if it is not, these conditions are not fulfilled, you will give them 0. So if somebody who's got a score of 0 to 1, the mortality is between 3 points. So still, like even with 0 score, you still have got a high mortality, high in the sense like, around like between 1 to 3%. So if there's somebody's got a score of 1, he would have a mortality of 3%. Out of 100 people, 3 would approximate die. If the score is 2, the mortality jumps up to 12%. If it is 3, it even jumps up to 35.8%. If it goes to 4, then it is 58.3%. And if it is the score is 5 or higher, then the mortality is 90%. So like very, very high mortality rate if the score is 5 or more. So Scorton criteria is used for classifying the severity of the illness, and that predicts the mortality in this particular condition. Moving on about the mucosal involvement, because hallmark of SJS is mucosal involvement. So any mucosal involvement can involve the eyes, which can start with painful red eyes, and they would lead to conjunctival and corneal ulceration. So if there is central corneal ulceration, that can lead to visual loss, and in severe cases it can lead to endophthalmitis, which means inflammation and infection of the whole globe, and can lead to permanent blindness. It can involve the oral cavity in the form of severe aphthous ulcers, severe oral ulcers, and that would call odynophagia. That child would not be able to eat or drink anything, so obviously that would lead to dehydration, because that child is not eating anything. Nasal cavity involvement can occur in the form of nasal mucosal ulcer. Similarly, genitourinary surfaces can be involved. That would lead to severe urethritis. That would lead to dysuria. In females, it would lead to vaginal inflammation, and the anal opening can also be inflamed, leading to proctitis, and might lead to constipation, because that child will be reluctant to pass stools. And inner GI surfaces can also be involved, can lead to severe esophagitis. Again, that would complicate duodenophagia and dysphagia in this particular case. So any mucous membrane can be involved, and in severe cases multiple mucous cavities are involved. Okay, now moving on to the management. As I told you, the first thing is to see the severity of the illness. So for that, I've already told you Scott and scoring systems. If somebody is scoring 0 to 1, that is 3%. If somebody scores 5 and more, that is 90%. Obviously, because these ultimately the surface is denuded, you need to treat the skin lesion and mucous membrane lesion as burn. So basically, these children, they need to be admitted in a high dependency unit and maybe transferred to a center where they've got special burns unit. So they have to be treated inpatient in a burns intensive care unit because of the complications, which would be the same in case of like a child who's got severe burns. All they need is supportive therapy. So in supportive therapy, the most important thing is that if you think there could be an triggering factor, okay, so avoidance of that, so that factor has to be removed. So if that has been caused by an antibiotic, you have to stop that antibiotic. If the child is using something which might have caused that, you need to stop that thing. So the first thing is to remove that triggering thing. The other thing could be supportive. They need IV fluids, because obviously burn would lead to fluid loss. So Parkland formula can be used for calculating the fluid. So IV fluids, nasogastric feeding, obviously because of a dinophagia, dysphagia, they will not be able to tolerate oral feeds. So nasogastric feeding. Pain control. Now pain control can be a bit tricky because NSAIDs can be associated with Stevens-Johnson syndrome themselves. So either you have to give them paracetamol, or sometimes you might have to give them, like, because obviously burns are very painful, so you might have to give them subcutaneous or titrated morphine or some other form of analgesia. Remember, that can be very, very tricky. So see if those drugs could be contributory, because if you start controlling pain with those things, which might have caused, it will just lead to aggravation of the condition. Blisters or the burns are just treated with burn dressings as you would treat any severe burns. And obviously they might need antibiotics to avoid secondary infection. And usually it is preferred to use topical antibiotics rather than systemic antibiotics. Again, depends on the condition, but wherever possible, topical antibiotics should be used. Specific treatment can be in the form of steroids, so oral steroids if the child can tolerate it, like prednisolone, high dose prednisolone, 40 to 60 milligram per day, or methylprednisolone is another alternative that can be given intravenously. And where steroids are not working, then intravenous immunoglobulins, or then certain types of monoclonal antibodies which are very expensive. They can also be used for the management of Stevens-Johnson syndrome. This is the same thing, the scoring system, which I discussed with you earlier, and the mortality associated with that. So I don't think we need to repeat that thing. Some of the things that can mimic Stevens-Johnson syndrome are included in the differential diagnosis. Is a linear IgA bullous dermatosis. Now, linear IgA bullous dermatosis is basically the pathology is different, but it presents very much like Stevens-Johnson syndrome, and they can have mucous membrane involvement as well. So the hallmark again is that if immunofluorochemistry is done for the skin lesions, there is linear deposition of IgA. So somehow the IgA attacks immunoglobulin A antibodies. They attack the cells at the junction of the epidermis and dermis. So instead of the CD8 cytotoxic lymphocytes which attack the cells in this SJS, here the culprit is immunoglobulin A, but the phenotype is more or less the same. Staphylococcal scalded skin syndrome basically is caused by overwhelming staphylococcal infections, which usually happens as secondary infection in burns as well, usually present with fever and diarrhea, and the toxins from the staphylococci, they usually cause like denuding of the skin and formation of the blisters. So that should also be taken into consideration where you think there might be risk factors for staphylococcal. Widespread bullous impetigo is another one condition. So bullous impetigo basically rarely can involve mucous membrane. Most of the time it's there on the skin, and there is usually honey-like incrustation on the skin, but usually the bullous form presents in the periphery in the form of bullae, and when the bullae bursts it leaves a raw surface. But usually the skin involvement is not that much widespread in case of bullous impetigo as compared to Stevens-Johnson syndrome. Then epidermolysis bullosa acquisita. This is basically an acquired form. Epidermolysis bullosa, basically minor trauma. There's usually history of trauma, like somebody bumped the foot or ankle somewhere on a hard surface, and after that, in a few days they start having a blister, which leads to bulla formation, and then it bursts. So, but usually it's more or less localized epidermolysis bullosa acquisitica, which is basically an acquired form of epidermolysis bullosa. And eczema herpeticum, those who have got the underlying history of eczema, they can have eczema herpeticum, which is basically herpes simplex viral infection on top of the eczematous lesions. So remember, in that case there should be history of eczema. Porphyria cutaneata is basically a condition, it's a porphyria condition in which there would be bullous formation, burns in sun exposed area. So there is usually photosensitivity, and here usually the the urine is positive for porphyrin. So porphyria cutaneata is one of the commonest type of porphyrias, and it presents with skin eruptions, bullous skin eruptions in sun exposed area. And then vasculitis are usually raised, and if there are inflammation of the small vessels in the skin, that can also present with skin lesions, skin swelling, and burns as well. Some form of Kawasaki illness, you might see that. So these are some of the differential diagnoses which you should keep in mind. So again, from the phenotype and from the history, it might help you in giving you a differential diagnosis. But again, it's not, there are no hard and fast rules where you can say, well, if that is present, you can swear that this is staphylococcal skeletal skin syndrome or something. I think the best thing is to do a skin biopsy in all these cases, because basically it's the immunofluorochemistry and the microscopic pictures which actually tells you whether this is linear IgA bullous dermatosis, whether this is Stevens-Johnson syndrome, or whether this is epidermolysis bullosa acquisita. So I think basically in the management of this condition, you have to involve the dermatologist at some point in time. Moving on to case number 2. Now this is a 2-year-old boy who presents with a generalized rash, as you can see in this picture, which is itchy, painful, and is associated with high-grade fever. So this is an itchy rash. It hurts as well, and it's associated with a high temperature, and the child looks miserable. He has been seen by his GP 3 days ago. He's already on flucloxacillin, which is not helping this child. This child has got a vast history of cow milk protein allergies, and he has 2 similar episodes of rash in the last 1 year. So if you look at the rash, let me show you the picture. So here is the picture. So if you look at the rash, you can see that it is maculopapular pinkish rash, slightly raised, and in the other picture you can see that the flexural surfaces are involved. So it's very much dense in the antecubital fossa. So these types of lesions, if they are itchy and they seems to be lichenified as well. So if you feel them with your hand, obviously you can't feel them in the picture, but if you see these patients' reality, and if you just try to feel that rash, so it feels raised, rough, dry rash, which is a hallmark of what we call as atopic dermatitis or eczema. So this is basically an eczema condition, but eczema can have flares up, and it can be secondarily infected. And one of the common things that usually becomes a problem in eczema is eczema herpeticum. So if the skin is broken and somehow the herpes virus gets into it, like they get a florid flare up of the eczema, and that can have serious consequences as well. Basically, as far as the pathophysiology is concerned, there are different theories about eczema. They are, so many theories, but like the common ones which usually have got role are: number 1, the epidermal barrier dysfunction theory, the immunological abnormalities theory, and the aggravating factors theory. So say the epidermal barrier dysfunction, they say that somehow there is a problem with the filaggrin gene. So the gene which encodes for the filaggrin, which is part of the connective tissue, is flawed. So that leads to an increased skin pH. So skin pH is increased, which leads to some decrease in the Staphylococcus aureus resistance, and that leads to increased allergen susceptibility. That can lead to decreased ceramides in the skin and decreased hydration, so the skin is dry. There's a lot of what you call dead skin in the top layers of the epidermis, which acts like a thin lichenified, and obviously because of the breakdown in the barriers, because of the impaired filaggrin between the cells, there is the bacteria can enter the skin and can cause secondary infection as well. They also say that there is some problem with the calcineurin mediated helper Th2 helper T cells activation. That leads to increase in the interleukins, which leads to increase in the serum immunoglobulin E, and that leads to increase in PDE4 activation, which leads to inflammation, increased cell turnover in the skin, leading to more cells in the outer layer of the skin, leading to this lichenification, calcification, itching, not calcification, sorry, increased lichenification, increased thickness of the skin, and also leads to itching. So this calcineurin mediated helper helper T cells basically has got role, and that's one of the reasons that calcineurin inhibitors, they usually act very well in this particular condition. And the third is that there might be aggravating factors like dry skin, using harsh detergents, seasonal changes, infections, sweating, things like food allergies might be associated with that. Again, there are different theories for that. There are association, nobody knows for sure, but again there has been an association, so they think that might be one of the reasons. So it seems like this eczema is multimodal in its etiology, different things when and the recipe has got all the ingredients and they get eczema. So the hallmarks of this condition is that there is lichenified skin with scales. So you will see lichenified, thick and chronic, leathery skin. Though scaling in adult scaling is present, in children scaling is not evident that much, but in adults you see that if you just take a sort of a metallic ruler and try to scrape the skin, you will see that the dead scales are coming off. So there is lichenified skin with scales, which is a hallmark because of the increased turnover of the keratinocytes. There is characteristic distribution and itchiness. So this characteristic distribution and itchiness is usually in small children, it usually starts from the face. So in very young infants, usually the patches, these thickened patches are on the skin, mostly on the cheeks, and then they are patchy on the body. So you might see a patch on the chest, might see a patch on the abdomen or on the back. But as they grow, there is more predominance of these lesions on the flexural surfaces. So usually the antecubital surfaces of the elbows, the wrists, the popliteal fossa, the ankles, they are involved. And as they get older, then it usually turns into chronic eczema, where there is chronic low grade inflammation in the elbows or in the ankles or in the popliteal fossa. So there is a characteristic distribution, and these rashes are itchy because there is dryness and the child tries to scratch the skin. It's also important, especially those male cases where they've got eczema and there are frequent hospital visits with superimposed infection. Check platelet counts. This is the most important takeaway message. If it's a boy with repeated coming to the hospital for infections and he's got a history of eczema, check the platelet count, because it might be a case of Wiskott-Eldrich syndrome. So Wiskott-Eldrich syndrome is X-linked recessive condition in which there is eczema, thrombocytopenia and impaired immunity. Now, thrombocytopenia doesn't mean that they will be having petechia. Petechia only happens when the platelet count goes down too much, and it might be low but it not be very low. So that's why check the platelet count, because in that case you might be able to rule out Wiskott-Eldrich syndrome, and then you can send them for genetics. How do you diagnose? Most definite test is skin biopsy, but skin biopsy is rarely done. Most of the time the diagnosis is clinical, and most common complication is secondary infection, especially eczema herpeticum. How do we treat it? First line treatment for mild cases is barrier cream, so you use barrier cream emollients. Second line is hydrocortisone for facial lesions, and depending on the severity of the condition, you can use moderate to high potency steroid creams for flared up regions. You can use either betonovate or dermovate, so depending, betamethasone or clobetasol, things like that. From moderate to high potency you can use it on the body, but for face we use hydrocortisone 1%. Third line treatment is topical calcineurin inhibitor. So tacrolimus 0.03% skin cream is very good if the steroid creams are not working. Fourth line treatment is usually done by the dermatologist, so they might have to start them on weekly methotrexate, and then you have also to give them some adjunct treatment for reducing itchiness like chlorphenamine syrup or hydroxyzine and emollient bandages, especially if the child is scratching themselves like crazy. And similarly, if they've got complications like eczema herpeticum, then you might have to treat it with topical and systemic antiviral drugs. This is the diagram which shows the distribution of pediatric eczema. So in infancy it's mostly on the face and patchy spotty appearance elsewhere. In childhood it's mostly the flexural surfaces, and then as they grow up, then in juvenile it either clears up or it leads to low grade chronic eczema. So the pattern, the distribution is very much characteristic, and as I told you that the diagnosis is all clinical, though if from exam point of view it would be skin biopsy, but I mean we don't do skin biopsy, it's all clinical diagnosis. So this was all about the generalized bullous eruptions presentation to the ED. I hope you have enjoyed this lecture. If you still got any question, put it down in the comment section below and I'll be more than happy to answer your queries and your questions. Please share this video with your friends, and if you like it, give me a thumbs up, and if you haven't subscribed to my channel, what are you waiting for? Come on, subscribe. Okay, it helps to maintain this channel. So have a very good day, take care, stay safe. Bye-bye.